Assalamu alaikum wa rahmatullahi wa barakatuh. I am your host, Muhammad Nazal. I am the coordinator of Just CRS. It's a co-funded project by the Erasmus Plus program of the European Union. This webinar has been brought to you by this project and also courtesy of Maharat platform, a new electronic platform at Just, Jordan University of Science and Technology, and offering skills and knowledge to everyone for free. And I am very delighted today to have Dr. Noor Ismail presenting about this amazing seminar and topic, sensory processing theory and application in ASD. Dr. Noor Ismail is a graduate of Just and also graduate PhD from Kansas University Medical Center. Please join me in welcoming Dr. Noor Ismail.
Hello, everyone. Thank you, Dr. Muhammad, for introducing me. I'm very happy to talk to you today about sensory processing knowledge and how we can apply this knowledge in serving children and families with autism spectrum disorders. Please don't hesitate to ask any questions when we finish this lecture. And again, I'm very happy for talking with you today. So our objectives for today will be, we will explain Dunn's sensory processing framework, and we will know how to apply the sensory profile in evaluating and characterizing children's sensory processing patterns, specifically for children with autism spectrum disorders. Also, we will discuss evidence-based interventions that support children and families' participation in everyday life. I'll begin with an introduction about sensory processing. So, sensory processing is the way the brain processes sensory information in order to provide output or responses. These responses can be behaviors or motor outputs, anything that shows that we are responding to these sensory input. So people are different in their ways of sensory processing. So some people shows some active ways, and some people show some passive ways, depends on how they process sensory information. And that will apply to Dunn's sensory processing framework. Basically, it's a modified framework from Dunn's sensory processing model. The model was proposed in 1997, and Dr. Winnie Dunn reframed this framework in 2014. So this framework takes from the neurology science knowledge and from the behavioral knowledge. So it considers the interaction between the neurological thresholds and the regulation strategies or self-regulation strategies. So as we look into the framework, it shows two lines or two continuum, one horizontal and one vertical. So the vertical line is the neurological threshold continuum, and the horizontal line is the self-regulation or responding strategy line. So the interaction between these factors or these lines results in 4 sensory processing quadrants, which all people have combination of all these 4. So theoretically, humans are consisted of all these 4 sensory patterns, or show all these sensory patterns, but with different degrees. Because we have different sensory systems, we can show seeking patterns, for example, in some sensory system, and maybe sensitivity pattern in other sensory system like visual. So what are these quadrants, or how can we define or characterize these quadrants? First, I would like to explain what's a neurological threshold. A neurological threshold is how slow or fast people can detect sensory stimuli. So if a person has a high neurological threshold, that means he requires more time to register sensory stimuli. Whereas if a person has low neurological threshold, that means that he is fast in detecting sensory stimuli. For self-regulation strategies is how people react to sensation. They might be passive or active. So a person with passive self-regulation strategy means he takes action to minimize or intensify his sensory experiences. Whereas a person with an active self-regulation strategy means that he don't take any action to intensify or minimize the sensations around him. The interaction between these, the different neurological thresholds, the high and the low, and the behavioral responses or self-regulation strategies, which are the passive and the active, results in four sensory quadrants, or four sensory patterns, which are registration, seeking, sensitivity, and avoiding. So what is a registration sensory pattern? So as we can see in this figure, a registration sensory pattern is a combination of high neurological threshold and passive self-regulation strategies. That means people with registration patterns are very slow in detecting sensory stimuli, and they do nothing, or they are passive and they do nothing to intensify these sensory experiences. They want more, but they are passive. They do nothing to intensify their experiences. They don't look for ways to have more sensory experiences. If we want to look at children with the registration pattern, it is also called low registration. That means they register less sensory stimuli. Children with low registration sensory patterns, they miss social cues around them. They tend to look inattended in the classroom. They miss their names when their teachers call them. They look indifferent, so we don't know if they are paying attention or no. These children benefit from more sensory experiences in the classroom, in the community, and at home. The second sensory pattern is sensation seeking. So sensation seeking is a combination of high neurological thresholds and active self-regulation strategies. People who are seekers are slow in detecting sensations, just like the individuals with registration, but they show active regulation strategies. So they look for ways to obtain more sensory input, or they look for ways to intensify their sensory experiences. For example, if we want to look at children, they may hum or produce noises, rock their chairs, touch everything, and want to hug their caregivers, their teachers, and want to be close from their friends. The third sensory pattern is called sensory sensitivity, and it's a combination of low neurological thresholds and passive self-regulation strategies. People who are sensitive are very fast in detecting sensations. So that's why they have low neurological thresholds. And but they are passive in the other way. They do nothing to minimize the sensory input. They detect more than others, but they do nothing to minimize the sensory input. We don't notice sensitive people around us very much because they have passive behaviors. But sometimes they do, when you ask them, they say, I'm getting bothered with the light or with the noises around, um, maybe around the classroom. So children who are sensitive have difficulties in learning because they notice more things or more sensory others. They may notice people coming around next to the door, or they may notice children standing or going outside, and this minimizes their focus and attention in the classroom. Um, even in research, children who are sensitive are less detected, or we don't know about them because they show passive behaviors. And the last sensory quadrant or sensory pattern is sensation avoiding. And it's a combination of low neurological thresholds and active self-regulation strategies. That means like sensation sensitive people, they are quick, people who are avoiders are quick in detecting sensations, and also they actively find ways to limit the sensory input around them. So they close the doors, they close the curtains, maybe they cover their ears. And we know about children who are avoiders because they feel frustrated when the family changes the routines, or when people come to their house. They even cry. They may go inside the room and close the door. So they prefer routine activities, and they prefer to be around in places with less sensory input. The reason why they prefer routines is that they can predict the sensory input in the routines, and so they have a way to manage these sensory inputs. So they have previous experience how to manage sensory input. Whereas if they have new events in their life, they don't know how to react, so they feel fussy, they may cry, and show what we call problem behaviors, or very poor social skills. Linking what we know about, I hope that I explained the Dunn sensory processing framework in a good way, because we will apply it to children with autism spectrum disorders. As some of you or many of you may know, it's autism spectrum disorders, or ASD, are a group of developmental disorders that are mainly characterized with limitations in social interaction and communication, and also present with some problem behaviors like repetitive behaviors and restricted interest. We use the DSM-V for diagnosing autism, and it's a newer version of the DSM-IV. Basically, in the DSM-V, autism is called autism spectrum disorders, and it's a group of 3 conditions, which is autistic disorder, Asperger's syndrome, and pervasive developmental disorder. So all these, we don't call them by their names. We call them ASD. It's different from the DSM-IV is that the Rett's disorder and the childhood integrative disorder is not anymore present in the diagnosis of ASD. In looking for the autism spectrum disorders conditions, The Asperger's disorder is the mildest form of ASD, followed by autistic disorder, and whereas pervasive developmental disorder has severe a severe condition with more impact on the child and the family. Looking in the diagnostic criteria for autism or ASD, we see that there are two mainly categories that should be present, which are persistent challenges in social communication and social interaction, and restricted repetitive behaviors or problem behaviors. So sensory processing issues or sensory processing challenges are considered one of the second category, which is restricted or repetitive behavior. So children with autism shows patterns of hypo or hyperreactivity to sensory input and some patterns of sensation seeking. And these are some examples. They are different in responding to pain, heat, cold, and they do excessive smelling of objects, and they touch things for their textures, and they are fascinated with lights or spinning objects. And these are some examples. So challenges in sensory processing or sensory processing differences is considered from the second category for autism diagnosis. And this is according to the DSM-V. In looking into the literature about sensory processing in ASD, so literature confirmed that children with ASD have different sensory processing characteristics than their peers. They show different registration, seeking, auditory filtering, tactile sensitivity, and why these have different names than the quadrant that I explained. They may use different tools to characterize sensory pattern for children. Also, children with ASD have greater sensitivities toward touch, taste, and smell, and have also auditory difficulties. They show more avoiding, sensitivity seeking, and low registration. What I learned from the literature is children with ASD have extreme sensory patterns. So they have low registration, they have seeking, they have avoiding, but they are more extreme, so that they have these characteristics much more than other children. As I said, there's variability in the literature in the utilized instruments for sensory processing. That's why we have different terminology like tactile sensitivities, seeking, avoiding, and also there is variability in the age ranges. So there's no enough studies in for example, one age range that show children with, for example, preschoolers has a hyporesponsivity or hyperresponsivity. So there's some limitations in the literature, but we know that children with ASD have different sensory processing patterns than children with typical development. So in general, children with ASD tend to have more hyporesponsivity. That's mean low registration, followed by avoiding than children with typical development. And there is some studies that shows patterns of seeking behaviors. How sensory processing affects daily life daily lives in children with ASD. A systematic review that looks at the impact of sensory processing on participation showed that children with ASD have difficulties in learning, social participation, sleep, and mealtime. This is because of their sensory processing differences. Specifically for eating and feeding, kids resist to sit on the table during mealtime, and they eat less variety of foods. For example, kids with ASD tend to like more food with less flavors or less intense flavors, like rice and pasta, and they will eat, for example, these items with less variety of other items like fruits, vegetables, or food with more flavors like spices. Also, children with ASD have difficulties falling asleep, and this is a main concern of caregivers as they take more time to sleep, and they have specific routines to follow. For example, a caregiver reported once that her child, before he or she goes to sleep, would bring all his toys and organize them from the biggest toy to the smallest toy. And if the one toy is missing, so they have all to look for this toy, and so that the child can put it in order and fall asleep. Actually, sleep is very difficult. Sleep time or bedtime is very difficult for all children, and that sensory processing difficulties adds to the challenges in children with ASD. Learning and education is an issue, especially if children like miss sensory input or have less attention, or if children avoid attending or looking to the lecture or paying attention to the teacher. Also, there are other daily life activities like play, sibling play, peer play that is commonly affected in children with ASD. From caregivers' perspective, so when serving children with ASD, we take into considerations caregivers' perspective, because family-based practice or family-centered practice is something important when serving children with ASD. So parents report many difficulties dealing with their children or completing daily life activities like self-care. So mealtime is difficult, toilet training is difficult, and visiting the dentist or having doctoral check or physical routine check is also difficult. Educators and parents also report difficulties in the classroom activities. Actually, people or teachers do report these difficulties as problem behaviors. So they usually misinterpret children's sensory needs that they into problem behaviors or some poor social skills in the classroom. The literature in relation to sensory processing and social functioning in ASD, the literature showed that specifically seeking and avoiding predicted lower levels of social skills. That means seeking and avoiding patterns are factors or associated in having less social functioning or less social skills. Also, sensitivity and avoiding predicted higher levels of problem behaviors. That means doing behaviors or actions that may be harmful for the kids themselves or for other kids. Also, sensory processing patterns associated with lower levels of social functioning and higher levels of problem behaviors. I mean, sensory processing patterns, all patterns. So these studies are examples of sensory processing and social functioning, and there are more studies presenting in the literature. So how do we evaluate or how do we characterize sensory processing in children? The sensory profile is a widely used tool in characterizing sensory processing in children. There are many versions, so I'm presenting the newer version, which is Sensory Profile 2, published in 2014. So it has an accessible language for caregivers, teachers, and professionals who work with the family and the child to understand sensory processing patterns. And it includes items that present in everyday life. So it's an example of activities that children and family do every day. There are many forms or many versions. We call them the sensory profile series. So these forms or versions differ according to the age ranges. So there's a version for infants, toddlers, the child sensory profile, which is the most commonly used, which is from 3 to 14 years. And we have a school version for the teachers to complete, and we have a shorter version, which is a quick view of child sensory processing characteristics, like maybe like in 5 to 10 minutes. Why we should consider an assessment tool for sensory processing that is that include daily life items or daily life examples. I'm speaking about occupational therapy practitioners who should provide services or interventions that match children's and families' daily routines and in their natural context, because the unique characteristics of daily occupations, meaning that what we do should be meaningful and related to our daily lives and our routines. And it should be done in the natural context, meaning that not in the hospital or the clinic. We should serve children and families at home, schools, and in the community. Therefore, if we want to provide occupation-based interventions in natural context, we should evaluate how children perform or participate in the context of everyday life activities. And specifically looking at sensory processing, it affects all aspects of the child's daily life activities. So it's difficult to look at it at the clinic alone. We should include caregivers, teachers, and other care providers in accurately assessing how sensory processing patterns interfere or support children's daily life activities or children's participation in everyday life activities. I'm focusing on the child sensory profile too, since most children with ASD getting diagnosed between like around the age 2 and 3 years old. And that's when we try to look more about how sensory processing affects children's performance and participation. So this form is for children between the ages 3 and 14 years. It is a caregiver questionnaire. That means caregivers like parents or any adult who take care of the child or know the child can fill out this form for the child. It consists of 86 items. These items reflect different sensory experiences in all sensory systems. So what I mean by sensory systems, like visual, auditory, taste, oral, movement, body position, all these sensory systems are covered by the 86 items. And we can calculate scores for all 4 sensory quadrants, like registration, seeking, sensitivity, and avoiding. So it's a 6-point Likert scale. That means caregivers or care providers can rate how their child perform or do these behaviors in reaction to different sensory input. The 6-point Likert scale range from 5 equal always to 0, which does not apply. If this sensory experience you don't know about it, or you did not experience it, or your child did not experience it, you can choose 0. That means this does not apply to my child. This is an example of one part of the sensory profile, and I chose auditory processing. So as we can see, the items reflect everyday experiences. For example, item number 2, the child holds hands over ears to protect them from sound. And when the caregiver reads this item, he can choose how often the child do this behavior in response to sound. He can, if the child, when he hears loud noises, put his hands over his ears. Always, the parent report 5. But if the parent see the child do this behavior occasionally, he can choose number 2. Or number 0 if this behavior does not apply to the child. So the items presented in the sensory profile reflect different sensory processing patterns. For example, items number 1, 2, and 5 are related to sensation avoiding. That's the abbreviation AV. Whereas item number 8, for example, is related to low registration, RG. So for example, item number 8, the child enjoys strange noises or makes noises for fun. It seems like the child would like to, he can make the noises or do noises in order, or enjoy strange noises, not avoid these noises. So and items 3, 4, 5, 6 are related to sensation sensitive, sensation sensitivity quadrant. Going back, not only we can have scores for the different sensory patterns or the 4 quadrants, we can also have scores for different sensory systems and sensory related functions like auditory, visual, touch, movement, body position, oral, conduct, and social emotional. So we can know exactly in which sensory system the child has sensation avoiding. For example, the child may show avoiding patterns in the auditory or visual sensory systems, whereas in the touch and movement, he's just like other children. His scores fall in the category of other children. Other parts or other forms of the sensory profile pediatric series, and these are older versions. The sensory profile caregiver questionnaire is the same as the child sensory profile 2 or the child sensory profile 2. but it has a narrower age range. It's from 3 to 10 years. And there's the sensory profile school companion and adult sensory profile. The Cronbach's alpha scores, or how the internal consistency of the items in the forms range from moderate to good, and this is what the author report, or Dr. Winnie Dunn reported in the manual for the sensory profile. So these are the older versions. So how do therapists address sensory processing challenges in children with ASD? We learned how we can evaluate or characterize sensory processing patterns. Now, what can we do, or how can we serve children and families with challenges in sensory processing? Basically, the interventions are grouped into 2 primary categories, which are the Ayres sensory integration, or ASI, and sensory-based interventions, the SBIs. So the question is, or as evidence-based practitioners, we should ask ourselves, are these interventions really effective or really address daily life challenges? Let's begin with Ayres sensory integration. So it is founded by Jean Ayres in the 70s. It's a play-based method. So it uses activities and play activities when working with children. For example, this intervention uses active engagement in sensory-rich activities. The therapist should mediate this intervention. So the therapist design and bring equipment to the child when he knows that the child has problem in specific areas or a specific skill. So he brings these activities that are customized to challenge the child performance in these. Excuse me. Challenge sensory processing, motor planning, as well as organization, sequencing, timing, and problem solving. So as we can look at these skills, these skills are very important for the child. If each play activity or activity that the child engaged in has these components inside them, so when the therapist uses sensory integration therapy, he challenges the skills or the required performance skills for the child to be able to perform the activities. So it's just like it's a bottom-up approach. When therapists work with children on the basic skills needed for performing or doing activities, the therapist is using a bottom-up approach. Whereas if the therapist is working on the actual daily life activity like handwriting or dressing, the therapist this way is using a top-down approach. And there is a debate around which method is more effective. Generally, occupation-based literature suggests that using a top-down approach is more effective than bottom-up approaches. The common or the most common bottom-up approaches we know as therapists include Ayres sensory integration, neurodevelopmental approach, biomechanical approach, which some therapists may use with their with their clients. These bottom-up approaches work on skills that are necessary for performing the activities, but there's a debate on how these bottom-up approaches support participation. On the other hand, top-down approaches uses occupation-based activities. What I mean by occupation-based is activities that are authentic to the child and family and are present within their daily routines. For example, mealtime or dinner time, and at the child's home, around the child's dining table, and working with the child and using these occupation-based interventions. When the child do these activities, it actually can improve the bottom skills like fine motor skills and other performance skills and the client factors that are necessary to complete these activities. And there's a debate about these interventions, but as occupational therapists, we always support occupation-based interventions. So usually sensory integration is done in the clinic. So the family should bring the child to the clinic or a specifically designed room that challenge the child's sensory processing and praxis. And this is an example of a swing that's present at a clinic that can challenge, for example, vestibular processing in children and can improve. And the child likes these. Please don't have these swings at home, and that's what makes generalizing interventions to daily life very difficult. Like swings can be important for children, and recommendations for parents to support or to improve their children's vestibular processing is to take them to the park. If there's no near parks, maybe to establish one at home or make something easy for the parents to do at home and to work on challenging the vestibular system with their kids. As we can know that the clinic is not always the best place in learning. Like we have examples from like my kids in situations sometimes they don't know or answer the question, but at home they talk, they speak, and they know more. And because home is their safe place, it's their way, it's where they can express themselves and learn more. And so that's why we should support caregivers or parents to perform interventions within the natural context. That means where the behavior or activity typically occur. The other category of sensory interventions are sensory-based interventions. So how these interventions are different from sensory integration is that SBIs occurs in natural environment and not in the clinic. So I mean by sensory-based interventions, maybe like sensory supports like weighted vests, brushing, bouncing balls, adapted seating devices, also some tactile items that help play, and some tactile items in the classrooms. In USA, there was some time when children with some sensory needs start using fidget spinners. They claim that it can support the attention or focus while in the classroom. And this is an example of SBIs. So also there's a debate on SBIs on if, because these tools or items does not naturally occur in everyday activities or occupations, so it has only a short-term effect. It may be helpful, but it should be it would be better if the therapist design more naturalistic or something that is related to the child natural context. I sometimes use scented erasers. My child likes to smell everything, and scented erasers like give him this sensory needs when he's studying, and he's more likely to be happy and complete his study or assignment. So it's getting more popular. So some shops are including clothes with some sequenced items, like when the child can play with them and they can touch his clothes and have this sensory need of touching and texture, and they need to touch different textures. So it's getting more popular, and people are starting to use them more, but the evidence around them is not very supportive. That's what we will see in the next few slides. These are some examples that are getting more popular. So squeezing balls, balls with different textures, scented erasers, and some colors in the pencils. The children likes them. It may be a problem for using them in the classroom, as they may distract other children from getting focused, or other children who does not really need these items. They call this as a sensory diet. So our Ayres sensory integration and sensory-based interventions effective? Both interventions aim to fix the child's autism. What I mean, the child's autism, is that the problems or the underlying problems in performance skills and client factors. How? Like we know, children with autism have problems in social skills and social functioning, and this is related to performance skills and client factors, and these two categories from the occupational therapy practice framework are related to the person and not to occupations and environments. Unfortunately, these approaches do not support the child and the family throughout the daily routines. For interventions that occur in the clinic and from the therapist perspective, it's difficult to know how family and child relate to these interventions at home, and if it's not part of the routine, they're not going to do it, or they will have difficulty doing it at home. So that's why it's not related that much to occupation-based practice. Some of these interventions are really expensive, like need specific place, like a clinic, equipment. These can go very high in price, very, very expensive. So there is a systematic review conducted in 2008 about the effectiveness of sensory interventions for children with ASD or autism. So these systematic reviews suggested that there's conflicting evidence about sensory-based and Ayres sensory integration therapy because there is a lack of uniform definitions for some terms. So these, for example, Ayres sensory integration uses terms and definitions different from other sensory modalities. That makes it difficult to have a unified outcome measure to test during, before or after the intervention. Also, these interventions, I mean by these interventions, the Ayres sensory integration and sensory-based interventions lack manualized approaches to the interventions themselves. I find it difficult to find a study that explains the whole intervention and just talk about what they did. And there are some small studies actually that talked about the intervention, but in general, the evidence or the available studies have like poor description of the actual interventions. There's inconsistency in the inclusion criteria. Like the age ranges and the characteristics of autism, how mild, how severe. And as I said, there's variability in targeted outcomes because of the differences in the terminology. So there's variability in targeted outcomes. I didn't see many studies that focused on the occupational therapy outcomes that were present in the occupational therapy practice framework. Instead, they used outcomes that's related to the person, like praxis, organization, sequencing, whereas the outcomes presented in the occupational therapy practice framework include participation, quality of life, well-being, occupational performance. So as an occupational therapist, I would like more studies to specifically link sensory-based interventions and sensory integration to participation, for example. So like participation is something very important and for families and children. Like being able to perform or be included in life events that are meaningful to the child and the family. And these life events happened at home, school, and in the community. So these limitations significantly contribute to the mixed evidence or conflicting evidence that this review present. So there are some good and some poor quality studies, but in general, there's this systematic review suggested limited evidence. A more recent review about the same interventions, which are Ayres sensory integration and sensory-based interventions, also suggested conflicting evidence. So for sensory-based interventions, the systematic review suggested that it's not effective. For Ayres sensory integration, there are some studies that shows positive effect, but they are small randomized controlled trials, and we can generalize their results to show like good evidence. We need additional rigorous trials using manualized protocols for sensory integration therapy in order to say that this intervention is effective. I included references for these studies, and I would be happy to share the PDFs with anybody who asks for. I usually look for systematic reviews for intervention studies, so that it includes all the single studies that were done in a specific time. So systematic reviews, usually we have new ones every 10 years, or when we have enough evidence to collect or summarize. And that was the newest one of systematic review that I have found, or up to my knowledge. So if anybody know more, I would be happy to know from him or her, and I would like to look at it if it's available. So there's some conflicting or limited evidence about the use of Ayres sensory integration and sensory-based therapy. So what can we do? What can therapists use to support children's sensory needs? I like some studies that look at activity participation of children and learning, and they all suggest the learning and participation should occur in the context of the original context of the activity. So if we want to work on classroom outcomes, we should work with the teachers to design interventions that maximize children's participation and performance in the classroom. If we work with the family at home, we should look at the everyday activities that family and children perform, and look how these activities are challenging, and look at the activity demands within these activities, and use our analysis skill to see what's the problem, so that we can support children and family in participating in these activities. If we do so, we can support generalizing the skills that we want, and the children are more likely to perform these activities successfully in the future. How can we do this? If we want to be occupation-based, therapy should focus on children and family daily activities and routines. So what do we mean by therapy? That means the evaluation and intervention processes should occur in the children and families' natural context. And I have to confirm that family should be included, because they work with their children best. They know their children and they work with them best. So if we have children in the clinic, we can do our best to ask them and their family to bring the activities or the items with us, the backpack for the learning outcomes, the meal if the therapy or the clinic happens to be at lunchtime. Maybe we can encourage families to bring their meal with them, so that we can watch how the child interact during meal time, and what specific items of this activity or sensory processing items that interfere with completing the meals, so we have to focus intervention on the families and children's daily routines. Still, we have emerging evidence about interventions that we can use. So if we can use Ayres sensory integration and sensory-based therapy with caution, we can apply these therapies to something happening at home. So if the therapist suggests using the swing, we can encourage families to provide these opportunities for children nearby parks, or maybe establish maybe a swing. There's a place at home. If we couldn't use our information from Ayres sensory integration and sensory-based therapies, we can still use some effective interventions, which is around environmental modification. So it's not something about sensory processing. Environmental modification is using the sensory processing knowledge to modify or adapt activities and environments around the child and the family. By modifying, I mean that modify these activities to support children's sensory needs. So what's an example for environmental modification is making the mealtime activity, changing the time of dinner, for example, in a time that is when the child have more energy or less energy, or is less frustrated. That's a way of adapting or modifying the activity. Environmental modifications changes the place where the activity happens to make it to support children's sensory needs. So it should be around the child's natural context, but with a little bit modification that's not affecting the family routine or the child routine. This is a study. It's not a systematic review. Actually, I didn't found a systematic review that's specifically related to this topic about environmental modification, and there's no enough evidence about environmental modification for sensory processing, but it just, I thought that environmental modification, so modify adapt is an intervention approach found in the occupational therapy practice framework. And I believe occupational therapists should stick to outcomes and approaches presented in this framework to support their therapy. So this intervention was explained in detail. So it was individualized to each child. So there is a description of the intervention for different families and how these interventions were tailored to the child and family routines and needs. After performing this pre-test, post-test repeated measures design, children's participation was significantly increased and caregivers felt more competent. So researchers in this study also looked at caregiver factors and well-being. So I mentioned environment modification. So I use adapt modify a lot in my intervention or in my consultations for family. There is other intervention approach that is not specifically related to sensory processing as environmental modification, but we can use the sensory processing knowledge within this intervention strategy. So it's called coaching, and there is abundant literature about how that supports the use of coaching. So it's not only related to OT, it's related to different professions. So coaching is basically supporting caregivers. I'm talking about children with ASD. So coaching basically is supporting caregivers of children with ASD to know their strengths and weaknesses in dealing with their children's sensory processing needs. So therapists who use coaching ask caregivers, for example, open-ended questions that allow caregivers to know more about the child's condition. For example, a therapist may ask the caregiver, how or what do your child do during the day? Maybe the parent will answer by saying watching TV, studying, playing with his peers. The therapist will reply asking, how much hours does your child watch TV? And maybe the caregiver will answer by saying, for example, 2 or 3 hours. And this way, the caregiver may notice that his or her child is watching more TV than performing other day life activities, and this may interfere, for example, with learning self-care skills or learning or doing like homework or learning or education activities. So this is an example of coaching. It's not like this is how coaching is done, but it's just allowing caregivers or empowering caregivers to know more about their child's strengths and weaknesses. Empowering caregivers is very powerful or very important in occupational therapy, as there's a trend that support family-centered practice. If we support caregivers, we make sure that they bring the interventions that therapists suggest for their children at home or in natural context. So this is a study specifically related to OT, and it shows preliminary supporting evidence for coaching interventions, and it used family-centered interventions around the child daily routine and activities. So this is adapted from a book that I like to read, which is a book that for occupational therapists to support children's participation. I put it in the references. I adapted the to reflect the occupational therapy practice framework, 3rd edition. If we want to look what's the emphasis in sensory integration, it focuses more on client factors and performance skills, which shows like bottom-up approaches, which is from our framework actually, but there's no link between these emphasis on these domains on participation. So there's poor link between client factors and performance skills to participation in daily activities. If we use the sensory processing knowledge, we focus on daily life activities and the demands of these activities. We can modify it and adapt it, and also we look at the context and the environment because it happens within natural context. We look at the behaviors or sensory behaviors within natural context, so we can adapt, modify the context to reflect or support children's sensory needs. And if we use the sensory processing knowledge, we will be more occupation-based or top-down, or use more the top-down approach. Specifically looking at the intervention approaches, so the occupational therapy practice framework present these intervention approaches: create, promote, establish, restore, maintain, modify, prevent. And if we want to look at the specific person factors like praxis, sequencing, or so we are looking, if we are intervening on these factors, we are using more the establish, restore intervention strategy, which is toward fixing the child condition. And if we evaluate using the sensory processing knowledge, and we want to adapt, modify the activities and the environment, we are using the modify intervention approach. So that was all for my lecture today. We finished early, actually. I'm happy to hear your questions or to answer your questions if there's any.
Thank you, Dr. Noor, for this informative presentation. There are some questions, actually.
Sure.
Okay, so I'll go through with you the questions. Okay. Okay, so do you also use the SPM, sensory processing measurement, or school? I think SPM.
Yeah, it's sensory processing measure.
And with ASD students, and is it more accurate than the sensory profile? What do you prefer?
Okay, so the sensory processing measure, it's more similar to the sensory profile, but it's not widely used or tested in the literature, so I don't use it that much. So if we look in the literature, the studies use the sensory profile to characterize children's sensory processing patterns, and I feel more safe to use this tool to characterize sensory patterns. So Dr. Wayne Dunn did a factor analysis to see how everyday activities relate to different sensory processing patterns, and these items happens in everyday life, and they truly reflect what is seeking, for example, or what's avoiding. I used the sensory processing measure before, and it's similar to the sensory profile, but it's not like widely used, and the behaviors or activities are not all of them are from daily life example or from everyday life behaviors. Does that answer the question?
Okay, so I don't know if there are any different questions. They have to write it down in the chat area. So we'll go through the questions all together. Okay. So so these assessment tools are in English. So how we are doing on the Arabic cross-cultural adaptation, and do we have Arabic versions of all these assessments?
Yeah, so we do Arabic version of the older version of the sensory profile 1997 and 1999 and 2002. And these are for the caregiver questionnaire, the infant toddler, and for the adolescent adult. And for the newer versions, which is published in 2014, we recently, I and a group of researchers got a grant to translate the child sensory profile 2, which is for children between ages 3 and 14, and we are in the process of getting the permission from the Pearson company. So I hope it will get published soon, the Arabic version for the child sensory profile 2.
Okay, great. Okay. So there's nothing right now that they can purchase and use in the Arabic language.
Oh, so Pearson company does not allow to purchase Arabic versions of the child sensory. It's not present. It's therapists in the Arab world uses the versions used in the research for the translation. So I don't know for the copyright issues about this thing, but there's no Arabic version that we can purchase from the Pearson website. But there is a version of the child caregiver questionnaire that was published from the translational research, and I see many therapists use them.
So for the regular therapists, and they want to do the clinician, they want to use sensory assessment. What's your suggestion?
I suggest using the sensory profile caregiver questionnaire, the older version. There are Arabic versions that therapists use. They can't purchase it online, but they can ask for them from the researchers who translated or from other research from therapists who already have them.
Okay, so can you give us an example of how can we discriminate between low registration pattern and hyposensitive?
As I said, studies in the literature uses different assessment tools so to characterize sensory processing patterns. So there is an assessment tool called the Sensory Experiences Questionnaire, and it uses the term hypo and hyperresponsivity. It's not widely used. It's only used for research purposes. So hypo responsivity is the same as low registration.
Okay.
It's not seeking sensory pattern. It's not the seeking one. It's the hyperresponsivity is related, or it's similar to the low registration.
Okay, so there are some people who want to email you. Can you just go to the first slide so that they can get your email on ordering the Arabic version on, or communicating to you about that?
Okay.
Perfect. So going to the questions. About vests.
Okay.
There's compression vests and weighted ones. Which is better?
Depending on the child's situation. Let's look at how all children reacted to weighted vest and compressed vest. So my child does not have autism, but he likes to wear tight clothes under his jacket or his shirt. And when swimming, he likes to wear a compressed suit. He don't like to just wear the shorts without any top clothes. So it depends if it supports the child's participation, like in going out or wearing the clothes so that he likes, or in swimming. So we can use them, but there is no evidence that we should use them if there's no preference from the family or the child, because as I mentioned before, the evidence about sensory-based interventions is not supportive. We can use them if the child likes to use them, and he can complete the activity like dressing or going for swimming or anything. If it supports his participation and the family and the child feel happy, we can use them.
Okay, so there's a question back to the question, I think back to the assessments, and how do you track as a clinician your sensory processing intervention? How do you determine that your intervention is working or not?
So how do we measure participation? Participation should be reported by the caregiver for if we are working with children. So if we want to use the knowledge from sensory processing, we also use interview with caregivers, and we use some outcomes or outcome measures that measure the parent's satisfaction and maybe health and well-being.
Okay, so that's a good question. So when we talk about sensory processing, sensory integration, what about feeding? What about feeding and eating interventions for ASD? Are they related to what you've been talking about today?
Can you please specify what feeding?
Well, the question is, can you talk more about the OT feeding and eating intervention for ASD? So that was the question. So if are they related, or do you get that into account? Do you get these information from the sensory profile, or just...
There's a section of the sensory profile about oral sensory processing. So it does not ask about specific feeding skills like from chewing, but it asks about how the child reacts to different textures inside the mouth. So for example, some children may gag or want to throw up when they eat pears, for example, which has maybe texture like granules or something like this. So, or when they eat leaves like lettuce or parsley, so they gag because it has more edges that touches the lining of the mouth. But they do well if we change some of the foods. For example, cooking the greens may help if the child wants or can eat it. The children would have less gag reflex or less reactions to eating these crunchy, leafy items that that have more surface to touch the mouth. Also, maybe we can replace some fruits that have crunchy texture to less crunchy texture. Depends on what the child prefer. And most children with ASD, they eat less fruits and vegetables, and they eat more starchy food like pasta, rice, bread. These items have less textures, less flavors. It's blank. So I think by talking to the family and actually watching how the child react to different textures might help. So suggesting some items to be removed or replacing or cooking some items may help. For children with feeding difficulties as problem in their like in the feeding system. So this is less of my expertise, but I only work with families and children around what is happening in the food and the environment that interacts with children's eating.
Yeah, I think definitely this is an area that we need to focus more, and maybe another webinar about that. But I think it's the same a clinical reasoning when you're using sensory processing for feeding and eating intervention for ASD. So again, people who are asking for the Arabic versions of the sensory profile, please just email Dr. Noor right away. And I don't know if there are any questions. Okay, can you please recommend some books, some that we can, it talks about the OT intervention for sensory sensory processing problems, and also picky eaters.
Okay, picky eaters. Okay. So there is a book for supporting children's participation in the community. It's by Dr. Dunn. I have it. I don't know if I have it in the references, but I can send it for anybody who would like to purchase it or know about it. The knowledge of sensory processing can be applied in different interventions. It does not have an intervention specific to it. For example, we are learning more about environmental modifications and how this environmental modification can support participation. And we do this all the time. We managed to modify our desks to support our work, and we managed to modify our daily routine so that we can go out without our children cry or be mad. So anything that modify or adapt our daily routines and environments tend to be more effective than focusing on specific skills. So there are chapters in occupational therapy for children about environment and context. Maybe therapists can start to begin with and read. And now I read more about coaching, and coaching also is not specific to sensory processing. It's an intervention that you can utilize many the sensory processing knowledge or knowledge about the motor control or motor learning inside it to support children's learning, to support children's participation.
Okay, so about, and go ahead.
Yeah, specific, send it by email. I don't know the authors and the specific titles, but I have them in my office, and some of them are at home. I can send it for anybody who requests them.
Okay, perfect. There's a question. Okay, so when should we go with challenging the child gradually, and when to go with the adaptation, or giving him the input he needs, or just go ahead.
So there is evidence about using occupation-based top-down approaches. And then within these activities or occupations, we can use our knowledge of activity analysis to upgrade or downgrade the activities to challenge specific performance skills and client factors. So for dressing, we don't need to teach, for example, buttoning or unbuttoning in some cultures who does not wear shirts, or some who does not need buttons, for example. So we use their clothes to, we start with their items to, and then look in these items to see how we can upgrade the activities to challenge specific fine motor skills, for example.
Okay. So that's a good question, which goes back to our philosophy in Just CRS, which is interdisciplinary programs. What is the role of physical therapy in children with ASD? And how can they use sensory processing, which is probably a new way of thinking? So what's the role of physical therapy?
So I have less knowledge about the role of physical therapy and working with children with autism, but if we want to look in the motor control and motor learning literature, the use of correct or appropriate sensory input supports the correct motor output or motor learning. So if the child avoid specific activities because of their sensory, these activities' sensory characteristics, and these activities happen to challenge the child walking and running. So certain adaptations using, for example, shoes or socks that the child needs or for their sensory input or their sensory needs, maybe it can improve the child's participation in these activities that are related to motor control and motor learning. I'm not sure if this helps, but like the sensory, the sensation is the basics for all outputs, and movement is an output.
So would they have better understanding of motor control if they understand how sensory processing is?
Well, they can design motor activities specifically for children with ASD because they have specific sensory needs. So maybe to support their fine motor skills or their sitting or standing, maybe they need to work around items that are included in, for example, fine motor skills. If the child avoids certain textures, these textures shouldn't be present in the in therapy, whatever they use. If they use activities or they use physical agents that the child does not like does not need them or does not support his sensory needs. I'm not a big expert of the role of physical therapists in children with autism, but I want them to think for the foundation of movement. Movement, it's a motor output and it needs correct sensory input to get to have the correct motor output. And any physical therapist can help me in answering, actually.
Okay, there's a question about SIT. The question reads, do the researchers support the SIT findings and improvements and changes seen in children with ASD? Does the research support?
Praxis test?
Yeah.
Okay.
Does it, does the literature and studies support the use of SIT?
So the literature and studies that investigated the effectiveness of Ayres sensory integration, they evaluated children using a sensory integration evaluation tool, and SIPT is one of them. So if we want to look at the outcomes, which is the intervention, as I said before, there's mixed evidence, and the recent systematic review that I presented show some positive effect of Ayres sensory integration, but these studies were small and they did not provide or explain their therapy. We need more rigorous studies to confirm that Ayres sensory integration is effective.
Okay. Sensory integration, sensory processing, we always study it in children. How about adults? Is there any application on adults? Is there any tip related to sensory integration and processing among adults?
They use the sensory processing knowledge to learn more about adaptability, resiliency, and these items that is more of the adult outcomes, so that how can people react or manage social situations. There's more evidence about anxiety in the adults, anxiety and sensory processing. There's emerging evidence. I read one abstract about stroke and sensory processing, so how sensory changes happens after stroke. So, but because it's one of the diagnostic criteria, or sensory challenges, one of the diagnostic criteria in ASD, that's why we study it or work with it more. And autism is a childhood condition, actually.
But there are some adults with autism. So do the adults with autism have the same problems, sensory problems as children? And do we use the same tips, maybe? Yes. Probably.
We have the sensory profile adolescent adult questionnaire. So sensory processing patterns does not change, or there is so they usually stay the same as children grow, but they become more extreme. So people who are avoiders will be more avoiders when they become older.
I think one of the most parents would ask, would this go away when they get older?
No, it will not go away. We are not working on the child's autism. We are working around problems in daily life, so we can minimize the impact of sensory challenges on children and family. We want to empower the self-regulation of the child so that he can know what he needs best. And for example, I am a sensory sensitive, and I can tolerate sensory stimuli, visual and auditory, to certain levels, and then I do what makes me more effective in performing my daily life. I close the curtains and I minimize the light. I usually use yellow lights, for example, because it's really better for my light sensitivity. So we want to empower children to know how to react or to adapt to these sensory stimuli. Instead of crying and closing the ears, maybe they can communicate or know what they need so that they can minimize or intensify their sensory experiences. Perfect. It will not go away.
That's now a very general question. Any advice for autism inclusion in the schools, or any inclusion criteria? I think from the perspective of sensory processing.
Yeah, sure. So I work with a school in Irbid to support children from the general population to be more to support their participation in classroom activities. And some children, they don't they have less attention. They sleep during class, and other children just the teachers claim that she found them under the table, around the tables, and they walk in the class to support their movement needs. So it's just breaking down, for example, it's just in general, breaking down the activities to be smaller, like 5 to 10 minutes between each activities, shows the best results. So children who are avoiders, who we need to tailor the interventions around avoiders, because they have they more need these supports and than other children. So we have to focus on the avoiders more in the classroom. We can still support other children by having a sensory station or a sensory table where children can pick items that make them support their sensory needs, so that they can write, they can read, they can touch. And this sensory table, it's found in many schools in USA, where children can express their sensory needs and just pick items that make them more focused. The classroom, so this should be tailored around people who have more problems, and in the literature, avoiders needs more support.
So, okay, what's the best way to deal with children with ASD if they have other neuro problems?
Like comorbid conditions,
yes.
Intellectual disability. What other neuro problems you mean?
Well, the question reads like that, and it says like teaching them standing, walking, probably if they have, like, I guess, CP and autism, for example.
There are motor problems as a comorbid conditions associated with ASD, but it's a small percentage of the children. And there are also intellectual disability or intellectual problems, also a small problem associated with the milder forms of ASD. What happens is just we look on everyday life activities, and we tailor the intervention that supports the child's performance in these activities. We choose these activities to challenge or to match the child's sensory and motor needs together. If this is the question. So because children are learning new skills, it's not just like, it's not a rehab, it's just learning. It's a learning. They have this condition from birth, so they learn new things. So handwriting it has a motor component, and we just modify the activity to match the child's sensory needs. And by performing these activities successfully, the child fine motor skills, stability, posture can be improved.
Okay, so if we can ask you this question, what is the sign? What are the red flags that tells you as an OT that this child needs rehabilitation intervention?
For autism?
For sensory processing, let's say.
And it depends. So caregivers or parents report difficulties in dressing, for example, or in eating, and they want to know if, and they happen to know that their child have autism, so they seek services. For example, the red flags for occupational therapist is when there's something that interferes with everyday life activities and occupations. This is important to include the caregivers and other care providers like the teachers. The teacher reports having less academic outcomes, maybe more problem behaviors, and these we know because they have autism that these problem behaviors may be related to their sensory processing patterns. So for me, I don't work in a specific autism center, but I consult families with children with autism depending on their specific problems, and they usually report problems when people come to their house, like self-injurious behaviors, hitting, other problem behaviors. So this is
so mainly participation.
Yeah.
Okay. What about certification? There are always questions about certifications and the use of sensory integration, sensory processing, whether assessment or intervention. What's your take on that? Should we be certified?
So I think that occupational therapists need to increase their knowledge, and if the sensory integration certificate helps them know more and secure a job, it's very helpful. But on the other hand, it's very expensive. So we just have to outweigh the benefits and the other factors like expensive, and it consumes time. So if it helps, sure.
Okay, so I think we can't go. There are a lot of questions actually, but we cannot go over all of them. Okay. So what's the best way to clarify and it is to distinguish between sensory problems and behavioral problems?
In autism?
Yeah.
The behavior is something is the reaction of children and individuals to sensory to different sensory events around them. So what do you mean by behaviors? Is just like can you give me an example?
Getting attention.
Okay, so getting attention, it's different from sensory processing. Actually, if it's I think there is an assessment or something. I once heard about it that distinguish if this is a behavior that needs applied behavioral therapy or is just a sensory need. I'm not an expert in behavioral therapy, and I don't support this kind of intervention, as it just looks more on the specific person's skills and performance skills and the client factors. But it's just I heard about it before, and I can look more if somebody is interested, but it's just not my areas of expertise.
I would also suggest that you have to consider the two problems together and to check, because maybe this behavior is related to sensory problems.
Yeah.
And observe the child again and again, so you can understand the real situation.
So I read a story about a child with autism who happened to eat dirt or mud, and it just was a sensory need. So the occupational therapists who presented this case study advised the caregiver to look about items that are similar to these, and they happened to find the applesauce. The child likes it, and gradually his behavior was less, or something like this. So it's just this case study was related to sensory processing, and just as you said, Dr. Muhammad, we had to look at this or explore this behavior more to see if it's really related to sensory processing or no.
Okay. Thank you so much for this valuable presentation. Thank you so much for all the information. Thank you, Dr. Noor, and enroll in Maharat platform, because we have coming soon online courses on rehabilitation. So thank you so much. Thank you.
Thank you, Dr. Mohammed. Thank you. Thank you all for attending.